Good day, dear colleagues. This is Dr. Jihad, and our today's lecture is a continuation to the series that we have started, What Surgeons Should Know. And today we are going to talk about rectourethral fistula, as you see in front of you, or the abnormal connection between the rectum and urethra. And as you see in this picture, actually we have a connection between the rectum and the prostatic urethra, which we will see it is the most common site, and actually we will talk about the etiology, and we will see that prostatic cancer and the treatment related to the prostate is the most common etiology. We will review the different type of fistula we have, and we include in this category simple and complex fistula, and we will see that simple fistula may be treated with fecal diversion. This is actually permanent or temporary stoma, which will divert stool from the affected area, and this actually may heal up to half of the simple fistula, and we will define simple fistula in the next few minutes. Okay, also when we will start to talk about the complex fistula, we start to talk about the multidisciplinary team. We start to talk about the role of the urologist and gynecologist in the approach and treatment of this condition. And also we will talk about the diversity of a treatment option. We already talk about fecal diversion as a simple procedure, and we will talk about the graft interposition, actually putting a tissue here between the two affected organ. The tissue should be well vascularized, good tissue quality, and also we will see how some causes actually of fistula may be hard to treat, and here we are talking about, for example, the radiation-induced fistula, and how may this be a risk for permanent fecal or urinary diversion. Of course, we have a concept called the congenital complex fistula or congenital rectourethral fistula. We will review some. This is actually, we will review it in the pediatric lecture when we start to discuss some colorectal issue related to pediatric patient. In this lecture, we are going to talk about the acquired type of a complex fistula, namely the rectourethral fistula. Okay, and regarding the etiology, as we previously said, that prostate cancer surgery is the most common likely cause, iatrogenic in another word, and here we also this highlight on the approach for treatment of prostate cancer, as recently we are talking about the multimodal approach, the radio therapy and surgery, which increases also the complexity of the fistula itself. Also, we have to keep in mind that inflammatory bowel disease, pelvic infection also, but in a less frequent actually manner. Trauma, perineal trauma to the perineal region due to road traffic accident, patella, pelvic fracture, also part of the etiologies. Here we are talking about the retropubic prostatectomy, regardless of the type of surgery. It's open laparoscopic robotic surgery. We are talking about fistula in a range between 4 to 5%. Actually, to imagine what we are talking about, this is actually the prostate. We know that through it comes the prostatic urethra, and between the rectum and the prostate, the anterior wall of the rectum and the prostate, only we have the novellar fascia. So actually nothing exists, so it's vulnerable for fistula. Of course, many of the rectal injury during prostatectomy are unrecognized during the index surgery or failed to repair. If you imagine, actually what we need, I'm not an expert in the urological surgeries, but in prostate cancer they used to remove the prostate with the prostatic urethra, so they have the retrovesical anastomosis or vesicourethral anastomosis. They connect the distal urethra or distal to the prostate urethra to the urinary bladder, and you can see that how much the rectum is near and can be injured. Here is actually the most likely site for fistula, near the vesicourethral anastomosis after prostatectomy. Okay, we said that rectal injury can be unrecognized or can be due to failed repair. Okay, the rectal injury after prostatectomy, it's about 5%, which is appreciated percent. Let's say, risk factor, less common risk factor, these are the age. Of course, the age, the more likely, the advanced age, the more likely to develop fistula, TURP, bacterial prostatitis, hormonal treatment, and perennial surgical approach is associated with higher fistula also. Here we mandatory have to talk about the radiation, and we said in the last few years we start to talk about radiation as a treatment, and sometimes it may be the only treatment for prostate cancer in some stages. So we are talking about the radiation and how can you can imagine here before 1997 actually less than 4% of patients were treated with radiotherapy. Nowadays we are, or after 1997, more than half of the patients are treated with radio as a main treatment or as an adjunct to other modalities. So we said that radiation may increase the complexity of the fistula itself. Of course, how does radiation can cause fistula? Microvascular injury, mucosal ischemia, tissue fibrosis, and actually if we are talking about if radiation is used as a single mode of treatment, so this leads us to which type of radiation. Is it external beam radiotherapy or the more localized type brachytherapy? Actually, I'm not an expert in radiotherapy, but you can see here in the picture, this is an external beam radiotherapy, this is brachytherapy. Actually, I understand it as a more focused to a one field. Actually, brachytherapy is associated with a higher, a little bit percentage of developing fistula. Also, we have the cryotherapy. It's also localized type of radiotherapy associated also with appearing of fistula. As you see, external beam radiotherapy, it's 1%. If we are talking about radiation as the only treatment option, so external beam radiation can cause fistula in 1%, and brachytherapy 3%, cryotherapy up to 2%. What I can conclude that brachytherapy is higher than external beam radio therapy. The most complex type of fistula, these that appear as a recurrence after a treatment and completion of radiotherapy. So recurrence after external beam radiotherapy, and you did a salvage therapy, whatever the salvage therapy, surgery, cryotherapy, brachytherapy. So these patients actually have the higher risk for complex. So we are talking about patient treated, recurrence, we are moving to another surgery as a salvage therapy. Whatever the type of salvage therapy, these patients have the highest risk for not only fistula but complex fistula. Of course, we have to keep in mind that this type of radiation may lead to rectal cancer. Even this cancer actually can develop up to 15 years after finishing the radiotherapy, and rectal cancer can cause fistula. Actually, we will see that biopsy from the anterior rectal wall is also a risk factor for developing fistula, and not only fistula, actually stricture, which may synergize actually the appearance of fistula. So urethral and rectal stricture can appear due to the radiation. This is how can radiation participate in the fistula. We said also rectal surgery or anal surgery can appear can be a cause of rectourethral fistula. Rectal biopsy, if I'm going to do rectal biopsy, whatever the reason, but even especially those in the anterior wall. Other causes, let's say, less malignant or benign causes. Fistulotomy can causes rectourethral fistula. Stapled hemorrhoidopexy, which if you remember in the lecture of when we talk about hemorrhoid, we advise that stapled hemorrhoidectomy to be done in an experienced colorectal surgeon, and we advise you to avoid it. So you can see here that this may be a cause for rectourethral fistula. This is how external beam, brachytherapy, cryotherapy. This is how stapled hemorrhoidopexy looks like. This is the vesico urethral anastomosis, where it's most likely to appear. And let's move to the clinical presentation. Okay, how does this fistula present? First of all, we have to remember that actually if it is due to prostatectomy, so the symptoms more likely to present within the first 2-4 weeks after surgery, while if it's due to radiation, so as we said, it may be prolonged up to 14 or 15 years after the last dose. The symptoms actually can be, it's a connection between the rectum and the urinary system. So stool can migrate to the urinary system and present as fecaluria, as you see here, feces with urine, nematuria, pelvic or bladder pain. Also, urine can present through the rectum, urine per rectum, recurrent UTI. Up to 80% of these patients have actually erectile dysfunction. What else we can, regarding the diagnostic evaluation, actually this depends on proper history and physical exam. We will see that the role of imaging actually is additionary or adjunct to our physical exam. Actually, what we expect to find a defect in the anterior wall of the rectum that is 4 to 5 approximately, and usually from the anal verge, 4 to 5 from the anal verge. Okay, how to detect this defect? With physical exam, it's better with a cystoscope or colonoscopy. And actually, as you see here, this is the cystoscope. We will see a defect actually posteriorly here, or during the colonoscope. It's the endoscopy, let's say. You may use a proctoscope or sigmoidoscope to detect a defect in the anterior rectal wall. And what else we want to add regarding that? We have to document the size, the location, and the quality of the surrounding tissue. This may also play a role in the treatment, in our treatment. Also, while performing these modalities of diagnosis, we have to do biopsy if we have any suspicious for malignancy. The voiding, we will see voiding, cystourethropy, and barium enema. Actually, these are additional imaging if we need additional information. What I mean that you may not require, these are not mandatory through your evaluation. This is the voiding urethropy. This is actually retrograde urethropy or vasicography, I think it's called. It's actually a contrast in the urethra, and you can see here that we have a tract that and a leakage of contrast to the GI or to the lower GI, to the rectum, and this is actually a fistula over here. We can use also a retrograde gastrografine enema through the rectum, which we may show also, but again, this is not mandatory. This is if the diagnosis is questionable, equivocal, we didn't reach any good information from cystoscope and colonoscope or lower endoscope. Also, another imaging such as CT and MRI. Again, this is if we need more information about, if we have not enough information from the previously mentioned modality. We have to remember that if the patient if this patient with rectourethral fistula have any type of, or let's say severe urine incontinence or voiding dysfunction, this may actually highlight on the need of permanent urinary diversion. So we need, during our diagnostic evaluation, to assess the function status of the urinary system. If we have for example, severe incontinence, voiding dysfunction, this may push us toward permanent urinary diversion. How can I assess the function of the urinary system? We have the urodynamic evaluation, and actually this is not the subject of our lecture. Okay, regarding the classification, actually we have two types of classification. One with more details and not all surgeons accept it and use it, but actually it's the principle behind it to classify the patient. Are they radiated or not? And actually this highlight on how radiation can worsen the picture of fistula. This classification actually divided the patient to 5 stages. First 2 stages without those patients who does not take radiation or not related to radiation, and actually classify it to stage 1, less than 4 centimeter from the anal verge, means low, or dentate line and below. And if patient not radiated but have higher fistula at the level of dentate line and up more than 4 centimeter, we are talking about stage 2. If you are talking about patient who takes radiation, so we move to stage 3 directly. And actually, the here not the location or not the distance from anal verge, but the diameter of the fistula, which that play role or will differentiate stage 3 and stage 4. Stage 3, it is less than the diameter is less than 2 centimeter, and stage 4, those patients who are radiated and have a diameter more than 2 centimeter. So patient with radiation, we are talking about stage 3, 4. We do not take care to the location, regardless of the location from the anal verge. What is important for us is the diameter. Less than 2 centimeter, stage 3, more than 2, stage 4, and we have stage 5. This is ischial decubitus fistula. Actually, as I said, this classification, as you see, not all authors have adapted to it actually, and many surgeons actually uses the classification that you know, simple and complex fistula. Okay, what do we mean by simple fistula? We mean that actually all of them should be met. It should be less than 1 centimeter. We are talking about the diameter. The patient should be non-radiated, not due to radiation, have minimal symptoms, no sepsis, and no previous attempt to repair. Any of these not present, we are talking about complex fistula, more than 1 centimeter, history of radiation, cryosurgery, stricture in the urethra or rectum, sepsis, previous failed attempt. We are talking about complex fistula. If you notice, they do not highlight on the location, proximal to dentate, distal to dentate. Some literatures actually says that distal fistula are simple, or that is near low fistula, which is near the anal verge, are a simple, and more proximal fistula, more up fistula, are complex. But in this literature, actually, they do not highlight on the location when they classify the fistula to simple and complex. Again, simple, less than 1 centimeter, non-radiated, minimal symptoms, no sepsis, no previous repair. While complex, larger than 1 centimeter, we are talking about the diameter, radiation, cryotherapy, stricture, sepsis, previous failed attempts. The management of rectourethral fistula, and here we highlight on the importance of the multidisciplinary team and the sometime need for staged treatment, and the variety of the treatment we will see and will highlight the most important approaches we have to know. Okay, regarding the approach to the treatment of rectourethral fistula, actually this depends on what we already discussed, simple or complex, and we will see how does this reflect the treatment protocol we use. So depends on the size, site, familiarity of the surgeon. Some surgeon prefer some approach while other does not prefer some approaches. So this also the preference of surgeon play a role. What I want to highlight that if the rectourethral fistula due to neoplasm, cancer in the rectum, in the prostate, in the urinary bladder. So the treatment of fistula should follow the guideline of the neoplasm itself, not the fistula, not removing the fistula tract, or the approach we will talk about them in the next few minutes. So our treatment protocol should be guided by the guideline of the treatment of the neoplasm itself. Also in Crohn's disease, we do not push toward removing the fistula and putting a graft. As we will see, we will maximize the medical therapy, and this is in different form. For example, the use of infliximab, the usage of long-standing ceton, also maximizing the medical therapy. So these two separate entities have different approach. We said that the management is MDT. This is multidisciplinary team. We need the colorectal surgeon, the urologist, the plastic surgeon. When we start to talk about the rectovaginal fistula, we need the gynecologist. And actually, we will see that many fistulas will heal without actually any surgery or without manipulating the tract itself. Actually, what we need is just urinary diversion in a form of Follis catheter or suprapubic catheterization, or fecal diversion. And just when you actually give this area time to rest, a spontaneous healing will occur. Okay, this is actually, we have a picture here. This is in my notes, just I summarize the different approaches we have to the fistula. And actually here just they talk about our initial assessment we talked about, and we said that the initial MDT assessment start with history, exam, anoscopy when we talk about colonoscopy, and we said anoscopy, proctoscopy may be enough. They divided to initial assessment, secondary assessment. They said cystoscopy follows actually, or cystoscopy is part of the secondary assessment. Voidening cystourethrogram, we said that voidening cystourethrogram and retrograde urethroplasty is not mandatory, but also can add information when have equivalent exam, or when we have not enough information. And we said that actually CT and MRI is not mandatory, but as you see here, consider CT and MRI if we have not enough information from the previously mentioned, or if we have abscess, we are planning to put a drain. So we need some urodynamic studies. And we said that the functional assessment is mandatory because patient with functional disorder in a form of urine incontinence mostly will require permanent urinary diversion, unfortunately. And we said we have a specific condition that follow the disease itself, such as colorectal cancer, prostate cancer, and Crohn's disease. We said we have simple and we have complex fistula. And when we start, we said simple, this is usually small, non-radiating, minimal symptoms, no sign of sepsis, low usually. So we said that a significant number will heal with diversion alone. What's best, to do urinary diversion or fecal diversion? Of course, the easiest way is to do urinary diversion. In a case of simple fistula, we do urinary catheterization, Follis catheter, suprapubic catheter. We actually divert the urine and we will watch. If healing occur, we remove the Follis within 2 months to 3 months. If no healing, we start to talk about our approach. We have actually 2, 3, four main approaches in which we actually start to manipulate, to remove the tract, to put tissue between, additional tissue between the rectum and the prostate. And in simple fistula, if Fulis does not help, we move to local flap repair, and the simplest way is to use the transanal approach. We will see in the next few minutes that we have two approaches. These are the transanal and transperineal approach. In simple, in which urinary diversion failed, we go to transanal approach. If that failed, we move to fecal diversion. And if if our local flap in a form of transanal approach, you will get what does transanal approach means, and that we will talk about it. But if this approach fail, we move to fecally divert to do stoma, and actually to watch. If this actually fail, we think of the more a little bit complex approach, the transperineal approach, or just to repeat our flap through the transanal approach. When we start to talk about the transperineal approach, we means that we will bring tissue and put it, we will remove the tract and put tissue between well vascularized healthy tissue between the rectum and the prostate and UP. Okay, what I want you to remember, to summarize it: Fulis failed, success remove, failed, we move to local flap. We have two approach. Best to start with the transanal approach. Failed, we start to think of fecal diversion. Failed, we start to talk about either to repeat the transanal approach or to do transperineal approach. If it's complex, we say complex means high, severe radiocryotherapy, very symptomatic, sepsis, stricture, failed repair, following trauma. Some literature says, or some studies notice that usually fistulas after a trauma, perineal trauma, due to RTA, road traffic accident, battle, quarrel, are usually complex. So we said in simple, we go first to urinary divert. In complex, we go to fecal diversion in a form of stoma, plus minus urinary diversion. And of course, if we have sepsis, we have to drain it with the use of imaging study. We have now stoma, and we assess the patient, and we said that usually we have significant number of fistulas that heal without touching the fistula itself. It spontaneously heal just after fecal diversion. If it's healed, that's nice. Reverse and close the stoma. If it does not heal, we have to ask ourselves, is there any serious manifestation that may require abdominal approach? We will see what do we mean by abdominal approach. But this serious manifestation, for example, if we have positive margin, so we are talking about cancer. If we have non-functional bladder, and we said we have to do functional assessment of urinary bladder, for example, urine incontinence mostly will require permanent urinary diversion. If we have severe stricture in the rectum or in the in the urethra, if it is extremely high, so we go to abdominal approach. What we can do, we have many options. We can go to pelvic exentration, remove all the urological and GI content of the pelvis, and leave the patient with permanent urinary diversion and permanent colostomy or fecal diversion. Or we do cystectomy with urinary diversion, or we go to APR. These are radical treatments. APR, removing the rectum, anus, and leaving the patient with permanent stoma. Of course, we can do proctectomy with coloanal anastomosis. If this feature does not present, this serious manifestation does not present, we start to characterize the fistula. And actually to see, is it, I call them extremely complex, or actually, because it's like a grade, we move either to local flap in a form of transanal approach, and we said the transanal is the preferred for simple. But if we have, for example, complex fistula, and not all the criteria are met for complex fistula, not bad to think of the local flap in a form of transanal approach. But if we have severe radiocryotherapy history, if we have extremely high fistula, large diameter, we here start to talk about the main treatment. The main treatment is the transperineal approach. And when we talk about transperineal, we said that here we start to talk about the interposition, putting a tissue between the two structure, the rectum and the urethra. So again, just to summarize it, complex, fecal diversion, healed, good, reverse, not healed, any serious manifestation such as positive margin, non-functional bladder, severe structure, high, if yes, abdominal surgery in a form of pelvic exentration, cystectomy, urinary diversion, ABR, proctectomy and coloanal anastomosis. If no serious manifestation features present, we start to talk either transanal approach. Yes, we can start, but the main treatment for complex fistula with, for example, large, high, severe radiation is the transperineal approach, in which we use interposition flap. If the transperineal approach failed, of course, what we have in our hand more than to go for abdominal surgery and more radical treatment. There are other approaches. Actually, we are not talking about the approach. What you have to remember, transanal approach, this is for simple fistula. Transperineal approach, this is for complex fistula, and we will talk about them separately in the next few minutes. We have other modalities of treatment. For example, putting a clip, large endoscopic clip. We have actually a defect in the rectum, putting a clip over there. Actually, unfortunately, we have few patients that undergone a treatment through clipping. So we have no good information about that. But there is a concept called endoscopic clip. Puborectalis flap also we have. We will talk about it and I will show it to you. We said transanal approach, transperineal approach, transanal, transperineal, and we have what we call it the posterior approach. I will show it to you, but this is nowadays less commonly used. We will talk about it. Okay, I hope that I made it simple as much as I can. Now let's talk separately about, here you can see the approach to the urethrorectal fistula. We have the transrectal, transanal, transrectal. We will talk about it. Transanal, if we do not divide the anal sphincter, called transanal. If we divide the anal sphincter, we talk about the York-Mason approach. We have the transperineal approach, transabdominal approach. Also, we have posterior approach. I think we will talk about it separately. Posterior approach we have, and as we said, we have clipping, another modality of treatment, but we need more information about it. Let's talk a little bit about the and focus about the transanal approach and what we do in this approach. Okay, and we said the transanal approach is our preferred option for simple rectourethral fistula. This is the preferred option, and in another word, actually, this is the endorectal advancement flap. We talked about it when we talk about the management of anal fistulas, and actually it's extremely simple. Actually, we identify the fistula tract, the fistula opening in the rectum, actually, and we dissect part of the rectal mucosa and submucosa up to the rectal wall and muscularis propria. And you see here, we take a little bit of flap and we move proximal up. After that, we close the opening. Actually, here they put a mesh. This is optional. Putting a mesh. Sorry, it's here. We move here. We close. This is A, B. Here we close actually the opening, and putting a mesh is optional. And you see, when we remove the rectal wall, we have actually a defect of the part of the fistula. We remove it. We remove that part from our flap, and we bring the flap more proximal. Some surgeon says that prerequisites or what needed before surgery is to have redundant mucosa so that I can pull it a little bit and then I fix it. Some surgeon puts actually pararectal fat between the flap. It's optional. Strictures shouldn't be present. Actually, any transanal approach have disadvantages that it actually added stretches to the sphincter, and if we have any function disorder in the anal canal, such as incontinence and problem in defecation, this may worsen it. Of course, we put urinary catheter here. What else we can add regarding the transanal approach or the endorectal advancement flap? We said it's good for rectourethral. We said we shouldn't there shouldn't be any rectal structure or anal structure. Fecal diversion is not mandatory. And actually, what else here is the step we talked about. We use absorbable sutures to close the opening. What we didn't actually said that actually we need debridement of any granulation tissue of the fistula tract. We said mesh is optional. Tissue transposition, this is pararectal fat, is optional. And you see here we closed the defect. This is the simplest approach actually we have. There is another actually transanal approach called the Let's Go method. This is L-A-T-Z-K-O, Let's Go method. It's similar to rectal advancement flap. What I can understand from this technique, they actually do core out. They dissect around the opening itself and divide it to 4 quadrants, and they close it in the 3 layer. Actually, what we have to understand is the endorectal advancement flap for simple rectourethral fistula. This is a transanal approach. We move to the transperineal approach. Okay, transperineal approach, and to understand what do we mean by transperineal, actually this is the transperineal region. Actually, this is the anus. I remove it just to remove any sensitive photo. This is the base of the scrotum, and this is the perineal region, and here we will approach. We say transanal for simple. When we start to talk about transperineal, we start to talk more about more complex fistula. When we need, actually, it's mainly indicated when we need to use interposition flap. We want to put a tissue between the rectum and the urethra in a form of pedicled flap. Actually, we have 2 main option or two main flaps. These are the dartos muscle flap. Here, let's see the dartos. In my own note, I used to call it dartos. It's dartos muscle flap and the gracilis muscle flap. We will show them. Actually, the successful rate is up to 90 regardless of the radiation history, which is good. When we talk about the dartos muscle flap, we are talking about low-lying fistula, small fistula, and we will see that the patient should be put in a prone or jackknife position. We talk about the jackknife position. It's a prone, but we use to pint the table a little bit. So, and gracilis muscle flap, we will show it and you can imagine it in the next few minutes. Here we start to talk about a little bit higher fistula. So the differences between dartos and gracilis, it's the location. Dartos, low fistula, gracilis, a little bit large defect, a higher fistula, radiated, and the position is also prone or lithotomy position. To imagine what we are talking about, what does dartos muscle? The dartos muscle is one layer of the, if you remember when preparing in your residency program for the layers of the scrotum until we reach the testis, we have the dartos muscle. Actually, here it is. This is the cremasteric muscle. This is the dartos muscle. What we do is we dissect, we freed this muscle from the scrotum and bring it to the perineum to put it between the rectum and urethra. This is the dartos. Let's move a little bit. What we do first is, let's go to the dartos muscle flap. First of all, we do a U-shape incision, lateral to the perineum, back to the scrotum, and to the opposite side through the dermis and the dartos muscle. You can see this is what we mean. This is the anus again. This is the base scrotum, and we do a U shape until we reach the base of the scrotum where the dartos muscle exists, and we go back. Then what we do? We dissect to retroprostatic plan anterior to the sphincter. Again, if you can see here, we start to dissect. Actually, we remove this skin and we start to enter the space until we are anterior to the sphincter of the rectum and posterior to the prostate. This is the retroprostatic plane. And we identify the fistula and we go up the fistula in 3 to 4 centimeter. Okay. Then sometime after identifying the fistula, we close the urethral opening side and the rectal opening side. We use absorbable suture. If you remember in the surgical technique, that absorbable suture in the urological structure, so it will permanent, actually will cause stone formation and nidus for infection. So we close the urethral opening and we close the rectal opening. What's unique in closure of the unique opening is if we used to close it in a transverse fashion, not a longitudinal fashion. This is in order to not causing a stricture or stenosis and more narrowing of the rectum. And this is brought from the structuroplasty technique when we talk about Mikulay's technique for structuroplasty. Okay, we close the rectal defect, we close the urethral defect. Some surgeons uses to put mesh or buccal mucosa to augment the defect in both sides. This is optional. What else we can do? Then the skin is removed from the flap. to show you what we are talking. Actually, here, this is the flap, our flap, and this is the dartus muscle, and we remove the skin from it and we invaginate it in the space, in the retroprostatic space. Then what we do, we suture, of course, the flap to keep it fixed, and we close, finally we close the defect over a drain. I'm doubt that this picture will be helpful for you, because but you can see that they bring this tissue, the dartus muscle, and they put it between the rectum and the urethra. This is the first option, and then you close it over a drain. The second option is the gracilis flap, and just I bring this picture to show you where is the gracilis muscle exists. It is in the medial aspect of the thigh, a little bit lateral. We have the adductor longus, it's inserted in the medial aspect of the thigh. We can actually bring this long muscle and through the perineal incision, we will show you, through a perineal incision, we transposition it in the retroprostatic space. You can see that we can use this type of flap for higher complex, for higher fistula, and even in many cases we need to cut or tailor this muscle, because it's a huge, more than what we want. This is the gracilis muscle. Actually, this is the thigh, this is the adductor muscle. First of all, this marking should be done externally, and what we do in gracilis muscle, first of all, the gracilis muscle traced externally, we marked the gracilis muscle. It's usually 4 centimeter posterior to the adductor muscle, and what we do, a 3 small longitudinal incision over the course of the muscle. This is what we mean: 1 incision, 2 incision, 3 incision, and then we put a Penrose drain and we track the skin and we start dissection. Penrose drain are placed through the muscle, through this incision, and the distal insertion is cutted. Actually, if we go here I think the distal insertion, we cut it and we start to dissect the gracilis from the other structures through this incision, and we should be care about the small perforators from the superficial femoral vessel. We clip them and we dissect, and we start to bring this muscle more proximal toward the upper thigh. Okay, dissect from the distal to proximal, and if there is any small perforators, we clip them. Be careful that the major neurovascular bundle is near the pubic symphysis, 10 centimeter near the pubic symphysis, so it is in the proximal part of the flap. So what we do is we bring the muscle through the most proximal incision. I don't know why in this picture they cut through the whole incision, but we bring the muscle through the proximal part of the wound and we do a tunnel. Actually, this should be the most proximal incision. We do a tunnel to the perineal region. This is a large clamp. We do a tunnel and we invest. We put the muscle in this tunnel to reach the perineal region. Let's continue. Rotated until it reached the perineal region. We use A clamp, okay. Uh, okay, of course, we close this skin, we close this incision. Again, I don't know why they open the three incision. It's not a must. What is needed that through the proximal incision, through, let's suppose that this is the proximal incision, we put a large clamp until we reach the perineal region, and we close this incision over a drain. Then we move to the incision. You see here the perineal incision. Let's see. Scan. No, I think we miss something. What we miss is what we do here, actually you can see a perineal dissection proceed. Here we do an incision in the perineal region, and we actually insert the muscle through this incision, and we close this perineal incision. I hope you get it. Okay, this is the final way. Actually, first of all, we have to identify the gracilis muscle. It is near the adductor muscle. It's easy, I think, clinically it's easy to detect the adductor muscle. Then we do 3 incision, we put a penrose drain through them, and we retract, and we start to dissect the gracilis muscle. And then we actually disconnect it from the medial aspect. The most distal part of the gracilis is the medial aspect of, in the medial aspect of the knee. We disconnect it and we bring it through the most proximal incision. Before, and then we close the incision, we close the thigh incision, and we do a tunnel through the most proximal. I'm not sure this is the proximal or this, but what we do is a tunnel toward the anus and perineal region, and then we do a perianal incision, as you see here, a curved shape, and we actually through the tunnel bring the muscle through this incision, and we invest it actually in the in the retropubic space, and then we close it again over a drain. So we have 2 incision, 2 drain. I hope you get it. Actually, this is the gracilis muscle. So we have 2 approach. Again, what's important, we have 2 approach: the gracilis and the dartus muscle. The dartus muscle is the simplest one for low lying fistula. Gracilis, when we talk about more high, large defect, because it's a large muscle, and usually we need to modify the size of it. We need to cut off the muscle. Okay, these are the transperineal approach. What's about the posterior approach? Okay, the posterior approach, and what we mean by posterior, actually here is the approach. As you can imagine it as an incision in the below the sacrum and in the intergluteal cleft to reach first the posterior rectal wall. We will see here an incision here. This is a posterior approach. It was the main approach in the past 20 years ago, let's say, when radiation was not a part of the treatment of prostatic cancer, and the success rate is fairly good, 88, but this percentage from non-radiated patient. Nowadays we actually prefer for complex fistula the approaches that permit us to use interposition flaps. This is the perineal approach. Actually, the posterior approach have limited exposure, and of course we approach to imagine it. First we will reach the posterior rectal wall, we will cut it until we will reach the anterior rectal wall. So limited inability or inability to manage the urethral structure or bladder neck issue in general. We are far from the urethra. We're limited to use any interposition flap, and this is why we prefer the perennial approach nowadays for complex fistula. And even if the fistula is high, we start to think with the transabdominal approach or combined approach rather than the posterior approach. We have in the posterior approach actually two similar to each other technique, the York-Manson technique and Kraske technique. The York-Manson technique, just to explain for you, this is the York-Manson technique. Actually, what you see in front of you is this is the posterior rectal wall. We cut it with the sphincter, as you see. We cut the external and internal sphincter until we reach the anterior rectal wall where the fistula should be. We identify the fistula, we remove it, we may do curettage, and we close the defect in the rectum, and then we close the defect in the posterior rectal wall and the sphincter in layers, usually in 3 layers. Can be done as a staged or as a single procedure. What else I can add about this approach? So posterior sagittal division of the sphincter, what we divide: the rectal wall, the levators, the posterior rectal wall first of all, the sphincters and the levators, until we expose the anterior rectal wall and the fistula. The fistula then is divided, the urethra and rectal wall is repaired, and of course we close it or in a layer. Here is a sphincter, so I think this should be done by an experienced colorectal surgeon. And of the major complication, of course, we have an incision in the posterior rectum, so rectocutaneous fistula and sphincter compromise in a form of continence, incontinence can present. Kraske technique, actually what's different is that we do not do a sagittal division, it's a parasagittal incision. As you see in the picture here, it's a parasagittal incision. We remove the coccyx, we remove the anococcygeal ligaments, and we approach similar to York-Manson technique. It's a parasagittal incision, coccygeal resection, division of the anococcygeal ligament until we reach the posterior rectal wall. We cut, we reach the anterior rectal wall. It's actually logical that it's more invasive actually. Okay, we now reviewed the posterior approach. We move the transabdominal approach. Okay, transabdominal approach, actually here we are talking about more radical, more aggressive approach. When the previous transperineal and posterior approach failed to address the complex fistula, when we have positive margin, and this will require prostatectomy, cystectomy, and permanent urinary diversion. Also, if we have non-functioning bladder and we have urinary incontinence, so we need we said that this is associated with high probability of permanent urine diversion. These are some of the indication for when we have, for example, severe structured urethra and the previous failed attempt. Options, actually we have complex fistula between the rectum and the urinary system, so either removal the urinary bladder, cystectomy with permanent urine diversion, and what we do in the rectum, we repair the rectum. As you see here, this is not the Sir, this is not an example for rectourethral fistula, just for imagination. What we did is diversion of the urine and we preserve the continuity of the bowel. We repair the defect in the wall of the rectum and we remove the UP, the urethra. What other option is to remove the rectum itself? And actually here a big question exists. Can I preserve the rectum or I should remove it? Let's first of all review what option we have. You can see here I can remove the rectum and do coloanal anastomosis. And here I don't want to disturb you, many questions exist. For example, the advantages of the coloanal anastomosis is preservation of the continuity of the bowel. We have no stoma here. We just remove the diseased rectum. Many questions exist regarding the function of the anal sphincter, the function of the anus, the continence mechanism, etc. Other option I have that I can approach through the rectum is APR. Actually, removing the rectum with no anastomosis is removing the rectum and anus and permanent colostomy. This is also for just to imagine what we are talking about. Of the option and radical option is removing the rectum, removing the urinary bladder, removing any intrapelvic intestinal organ, any intrapelvic urinary organ, and patient will have two stoma, one for urine urostomy, other for the feces colostomy. This is more radical. Actually, pelvic exentration and APR of the more radical that we try to avoid them. So we have cystectomy plus urinary diversion, proctectomy plus coloanal anastomosis, APR, pelvic exentration. Okay, we said that. Please ask yourself, can I preserve, can I keep the rectum or not? Because your first attempt for pelvic surgery is the best attempt regarding the rectal preservation. So, should I remove the rectum if I have complex fistula, intractable, previous attempt failed? Should I remove the rectum? The question can be answered depending on three factors. First of all, regarding the tissue of the rectum and the surrounding tissue. Is it healthy enough to keep? Second question, is the defect over large or just actually no clear or no cutoff diameter, but they said over large defect in the rectum? It's best to remove the rectum. And actually, is there any available healthy tissue I can use it for a flap to interposition it between the rectum and the urinary bladder? Okay. If the answer is yes, I have a healthy tissue of the rectum and the surrounding mesorectal fat. If I have no huge defect in the rectum, if I have good tissue to put between the omentum, between the rectum and the UP, so we can proceed to two options. Either the omental flap, or these are type of pedicled flap. So we bring the omentum, I will show you a picture, to put between the rectum and the urinary bladder, and the other is the rectus abdominis flap. I will show you a picture. Please remember that any surgery here, we have first to do the urinary procedure, then to go for the any repair in the rectal wall. We said if we want to preserve the rectum, so my two options, we have two options. These are to repair the defect in the rectal wall, and to interposition either omentum, which will depend on the left gastroepiploic artery, or the rectus abdominis flap. I can show you. This is actually how we interpositioned the omentum, which will depend on the left gastroepiploic artery, and we repair the defect in the rectum and the UP. Okay, other option is that I know that most of you knows the transverse rectus abdominis flap. Here we have the vertical rectus abdominis flap. Yes, I know that this image for rectovaginal fistula, but it carries the same principles. Also, this is a pedicled flap and needs the help of plastic surgeon. What actually we bring this muscle and we put it between the rectum and urethra. Okay. Again, if I cannot preserve the rectum for it's a huge defect, very bad quality tissue, no ability to bring a viable, well vascularized tissue. So here we are talking about coloanal anastomosis, we are talking about APR. Okay, what else we can, other approaches, of course we talked about transanal, transperineal, posterior approach, abdominal approach. We have other approaches like, for example, the bilateral, as you see here, the bilateral puborectalis interposition flap through the transperineal, through the transperineum area, through a transperineal approach. Actually, as you see here, if we have, this is also just an anatomical picture, shows you the puborectalis muscle. What we do is we dissect, we cut it posteriorly, and we have actually, so, sorry for interruption again, I tried to reduce the noise in the background. So we have the puborectalis, we cut posteriorly over here near the anorectal junction, and we have actually now two strips. This is actually after dissection, upper and medial, and we engulf it, we rotate it to engulf the anterior wall where the fistula is. We repair the fistula and we try to cover the tract, the fistula tract with the puborectalis muscle. Actually, to be honest, I tried to review the literatures about the failure and success rate, but actually few that is written about it. Of course, there is other modalities of treatment, but they are not the mainstay of treatment. They are not the mainstream of rectourethral fistula management of this. For example, the fibrin glue injection. Again, this is, I think, vesicovaginal fistula, but the principles is the same. And this is what we call it, over the scopic rib. Also, few cases in the literatures that are described, so we cannot give final conclusion about the success rate, advise them or not, but they exist actually. This is actually how we put a clip. And okay, what else we have? I think the last of this lecture actually is a comparison between the different type of the approaches. I think I will disturb you if I start to discuss these actually numbers and percentage. Lastly, this is actually a table that just reviewed the different approaches with advantages and disadvantages. For example, the transanal approach, its advantage: minimal post-operative morbidity, mortality, short hospital stay, doesn't require division of the sphincter. It's stretching of the sphincter. This is transanal. actually of the disadvantage, relative small space to work in. Of the indication, we said simple fistula, small size, non-radiated, no ablative therapy. Of the transperineal, for example, of the advantages, wide exposure of the urethra and the rectum, various flap interposition options, facilitating the urethral reconstruction. Disadvantages, it actually associated with stress urinary incontinence, bladder outlet contracture, and its indication, we said the transperineal is indicated for complex large fistula if we have urethral structure, radiation, or ablative therapy. The transsphincteric approach, York Mason approach, of its advantages that it's a small morbidity, preserving the urinary continence. Disadvantages, small exposure to the urethra, rectal sphincter injury. We said that we need to cut the sphincter of the rectum. Not suitable for patients with severe proctitis. Relatively small maneuver space, small space where we work. Also, the transsphincteric approach or the York Mason is the small fistula, for small fistula, small size, non-radiated, non-ablated. And the transabdominal approach, we said here we are talking about the omental flap or the trump, the rectus abdominis flap. It's also for the complex fistulas. We reached the end of the lecture. Thank you. Bye bye. Finally, this is the outcome of the different approaches. I do not want to disturb you. Here is a picture, just summarize the approach, the transabdominal approach in which we may use the omentum, the posterior, we said parasagittal Kraske approach, and the posterior transsphincteric approach, the York-Manson approach, the transanal approach, which is preferred for simple fistula. Transperineal, we want to use interposition flap. So these are the different. This is a table just show you the advantages, disadvantages, indication. Actually, most of them are in the gray zone, but I think to discuss advantages and indication worth, for example, let's start from the most simple, the transanal. The transanal approach, we said this is simple endorectal advancement flap. So minimal post-operative morbidity, mortality, short hospital stay, not involving division of the sphincter. We said in the transanal approach we do not cut sphincters, we may stretch it. Disadvantage, it's relatively small space to work in. Indication, we said small simple fistula, small side, non-radiated, non-ablated therapy. Then we moved to the transperineal approach. We said this gives us mainly indicated when we want to use interposition flap, okay, such as dartus and gracilis, wide exposure of the urethra and rectum, various interposition flap, facilitating the urethral reconstruction if we have stricture. Of the disadvantage, it may cause stress urinary incontinence, bladder outlet contracture. Indication, we said this is indicated in the complex fistula, large fistula, urethral structure, radiation, history of radiation. Then we talk about the posterior approach, the York-Mason approach, transsphincteric. We said mainly we do not use these now, and actually these are transsphincteric. We cut the sphincter and we have two. We reach first of all the posterior rectal wall. We cut the posterior rectal wall, the levators and the sphincters, until we reach the anterior rectal wall where the fistula exists. So small of the advantage, small morbidity, preserving the urinary continence. We do not reach, actually this is one of the disadvantage, that we cannot reach the urethra. Okay. Of the disadvantage, relatively small exposure of the urethra, rectal sphincter injury, and we said we may deal with incontinence and rectocutaneous fistula, unsuitable for patients with severe proctitis. Of course, if I have proctitis and I cannot cut the wall of the rectum. Of the indication, simple fistula, small size, non-radiated. So this is similar to the transanal approach. If we move up to the transabdominal approach, we said we have many surgeries. It's like a more radical approach, salvage surgery, when the previously mentioned approach failed. So of the advantages of the transabdominal approach, enabling greater omental flap interposition. When we talk about the omental flap, which depend on the left gastroepiploic and the rectus abdominis flap. Of the disadvantage, intervening abdominal cavity. Actually this is abdominal surgery, and so when it's indicated, we said for high complex fistula that we cannot approach, when we have positive margins, when we have urinary dysfunction, complex fistula, non-functioning bladder, positive surgical margins. And we reached the end of our lecture. See you in the next lecture. Bye bye.